Hello, everyone. My name is Ward Detwiler, president of Imagion Biosystems, and it is my pleasure to be joined today by Dr. Mohammad Eghtedari, the lead principal investigator on our MagSense Phase 2 trial. Dr. Eghtedari, thank you for joining us.
Thank you for having me.
So to start out, can you tell us about your role at City of Hope and your focus in women's imaging?
Yes, currently I am the section chief of breast imaging. The breast imaging in City of Hope has about 5 or 6 radiologists dedicated to reading studies related to breast cancer. City of Hope is a high-profile cancer center focused on many types of breast cancers, including HER2 positive breast cancers that are the most lethal type of breast cancers.
For those watching who may not know, how did you first become involved with Imagion and the MagSense program?
So it comes to a few years ago. At that time, I was not at City of Hope. I was an assistant professor at the University of California in San Diego. And one of my colleagues came to me and said that there is a company who is working on a very exciting and innovative type of contrast agent for detecting HER2 positive breast cancer. And the reason why they came to me and asked me if I'm interested to work with your company is that I had a PhD. I obtained a PhD in detecting HER2 positive breast cancers using gold nanoparticles. At that time, I was a PhD student at the University of Texas Medical Branch in Galveston, and I had some publication on it. And I was happy to use my knowledge and expertise. And after reviewing the images from your company, I got very excited about that. I saw the potential, and I wanted to have a relation with your company.
Great. Well, we are thrilled to have you back as an investigator and to have you involved with the MagSense program. Just speaking about City of Hope a little bit more, I've worked with City of Hope in the past and have always been really impressed by the work being done there. In your eyes, what makes City of Hope the right site for the study, and what does your team bring to it as investigators?
So this kind of breast cancer is a challenge for treatment. So most of the time when the patient are diagnosed with this kind of breast cancer, they need to go to a center that has extensive experience, knowledge, and facilities to do specific MRIs and other tests to treat this type of breast cancer to get the best outcome. And City of Hope is among one of the top cancer centers. You can look at the ranking by US News, and you can see the City of Hope has a very high ranking in treating most complicated type of cancers in general, lung cancers, lymphoma, and other cancers, including the breast cancer. So when you have a product that is so specialized, you cannot go to a county hospital or any other like a small institution to test it, because probably they will not have enough patients to test it in terms of number, and also they don't have the facilities and expertise to deal with this kind of less common breast cancer. And so City of Hope appears to be a perfect place for your study.
Excellent. Moving into the problem that we're trying to solve in MagSense itself. For people outside of radiology, can you describe the limitations clinicians face today when diagnosing and managing HER2 positive breast cancer, particularly when it comes to evaluating whether the cancer is spread to the lymph nodes?
So yes, that is an important concept to understand. Then you will realize what is the potential for this product. What happens is that the breast cancer is the most common type of cancer among women, and many of us know somebody around us who has breast cancer. So in terms of the number of cancer, this is a large number of patients that we will see. Number two is that it is proven by large clinical trial that the treatment of the cancer can lower the mortality of breast cancer. There are many effective treatments for breast cancers. However, the best outcome for patient is achieved when we do the right type of treatment for the patient, for each individual patient, meaning that there is not a single type of treatment that would apply to all of type of breast cancer and all stages of breast cancer. Some patient will have a best outcome in terms of life expectancy if they go to surgery first. There are others that may benefit if instead of going to surgery, first you give them some kind of medicine to shrink or kill the tumor cells first, and then take them to surgery. That decision, whether the patient needs to go to surgery first or not, is highly dependent on what type of breast cancer it is, number one. Number two, how much spreading of the tumor has occurred, whether it has gone to the lymph node or not. This is called staging of breast cancer. Anytime that the patient is diagnosed with breast cancer, the best thing that we need to do first is to first stage the breast cancer to know what type it is, how much it has spread. Based on that, we have different guidelines and different treatment that would best fit that particular patient. So spreading the tumor to the lymph node is the first step toward spreading on other side of the body, meaning that the disease, when it's into the breast, no matter how big it is, usually cannot be lethal for the patient, and you can control it. But if it comes to the lymph node, it's the first step that is coming out of its original site. And that's where the problem starts. And then if it goes from the lymph node to the bloodstream, then it can spread to other critical organs of our body, including lung, brain, bone, liver. And those are the ones that will unfortunately kill the patient. So knowing whether the disease has started to come out of the breast, which most of the time, the first step is in axillary lymph node, is an important part of the information that any clinician need to know before they propose the proper treatment for the patient.
What are some of the ways you are, I guess, performing that staging today? And maybe what kind of standard of care imaging techniques are you using?
Most of the time, you start with mammogram. Then, depending on the status, we may go with ultrasound or breast MRI to stage to see how extensive is the disease.
So even with something like breast MRI, there are limitations. I mean, there's limitations with ultrasound, limitations with MR. Can you talk about some of the limitations around those existing standard of care techniques?
Both of these techniques, the ultrasound and MRI, both of them are dependent on the shape of the lymph node to say whether the lymph node is normal or abnormal. There is no molecular specific finding on ultrasound or MRI to tell us whether the cancer cell, the individual cancer cells are there or not. And it doesn't tell us what kind of cancer cells are there, because there are different types of cancer cells for breast. So these are called morphological findings. The problem with them are twofold. Number one, at early stages, when only individual cancer cells have spread, let's say, to the lymph node, the number of those cancer cells is not enough to change the shape of the lymph node. Therefore, the ultrasound or MRI cannot see them and will label them as normal while they have some cancer cells in them. That's problem number one. So it misses earlier stages. The second problem is backward. What happens is that there are other findings or the other conditions that can change the shape of the lymph node that are not cancer. And by mistake, they will be interpreted as suspicious on ultrasound or MRI. And that leads to unnecessary biopsies for the patient. Many of them come back as benign. Today, in today's practice nationwide, about 80% of breast and axillary lymph node biopsies come back benign. Those are basically unnecessary biopsy. We did a biopsy because we couldn't tell the difference between a shape abnormality from, let's say, infection, inflammation, vaccination that is causing this, not a cancer. And then we slow down on the number. To solve this, we need some kind of molecular evaluation. The molecular evaluation tells us not only there are individual cells, but what are the molecular profile of this tumor so that you can target the proper medicine for those kind of patients.
It sounds like what you're kind of pointing towards is something like a MagSense, where you see a unique signal and you know that because if you see this signal, something is there. Can you talk about how molecular MRI like MagSense might change, that standard of care practice or change your workflow in doing this nodal staging?
Number one, at the very first stage of cancer detection, for us to know whether there are cancer cells in the lymph node or not, and that is the one that a molecular target that can have a specific signature on the MRI, not just a general thing that you can see on an inflammation, infection. Something like that can tell us with higher certainty whether we have a disease in the axilla or not, to decide whether the patient needs any neoadjuvant or some medicine prior to surgery, or the patient can benefit from surgery. The second step is after you started your treatment, many of these patients at the end of the neoadjuvant is a treatment that is given to shrink the tumor prior to surgery. So at the end of the neoadjuvant, still the standard of care is to go and remove a representative lymph node from the armpit as a standard of care to know whether there is a residual tumor on that lymph node. That determines the next step of treatment, whether the patient needs chemotherapy afterward, after the surgery or not, whether the patient needs radiation to the axillary area or not. And even that one is, again, can be modified and can be more specifically known without the surgery. So at the time of doing surgery, currently, they also do surgery on the axilla to remove this lymph node and look at them on the microscope and say whether there is disease in the lymph node or not. So your product, not only at the very earliest stage of cancer diagnosis for staging, but at the end, at the time of surgery, can skip the surgery of the axilla and repeat the study with the MRI and determine whether there is disease in the axilla or not, to minimize the surgery for the patient and get the information that we need to define the next plan.
So you touched on something really important here, which is one of the real goals of the study, which is to validate the ability of MagSense to improve imaging, to help determine the extent of nodal disease with that greater certainty. And we talked about this, I think, in a lot of clinical and technical terms. But can you talk about what that means for the patient and for their kind of journey through this care pathway and their overall outcomes?
If you look at the history of treatment of the breast cancer over the years, you can see that there has been a lot of changes, mainly toward doing less surgery, being less invasive, so that the quality of the life of the patient of breast cancer is preserved after the treatment. 6 years ago, if somebody has a breast cancer, they would go remove the entire breast, remove the muscles of the chest, remove everything in the axilla to save the patient life. Maybe the patient life was saved, but after that, living with that condition and disability, from one point, you benefited the patient and saved the life, but from the other hand, you ruined the rest of the life of the patient. Over time, they decided, let's not do mastectomy, let's not remove the whole breast, let's remove just part of the breast, lumpectomy. But still, they would do a lot of surgery in the armpit. They realized that they can do it minimum. And instead of removing everything in the armpit that causes lymphedema, they decided to do something that's called now targeted axillary dissection. It means that they remove 1, 2, 3 lymph nodes that, for instance, they had cancer in them, and they leave the rest alone. And right now, there are certain cases that they would skip even that surgery. They will skip for the quality of life. The main purpose is to save patient life, but also preserve the quality of life of a patient, because that is also an important factor. Your product can move this one step forward and say that, you know what, even for the rest of the patient that you're currently doing that minimum surgery, maybe we don't even need to do that surgery, because we can give you the same information that you want to know about this lymph node without cutting this area. We can see it through the tissue with the MRI, with the molecular agent that can exactly tell us what is the spread of cancer cell without cutting the tissue out. So this is all toward making the patient's life better after the treatment of breast cancer, so that they can go back to normal life without disability. That's the whole purpose.
Just shifting gears a little bit slightly here. You mentioned that you'd served as an independent reviewer on the MagSense Phase 1 study in HER2 breast cancer. What stood out to you when you reviewed those results?
So there were a limited number of cases, but it was promising because it would show on those positive cases that we knew that the patient has a cancer on that lymph node, for instance, we were able to see a signal that would be specific only for those patients who have a positive signal over the background. So meaning that the quality of the image and the signal in technical term, the signal to noise ratio was high enough to detect those lymph nodes that have a cancer without falsely labeling those who don't have cancer in them. So that was an interesting preliminary result, promising results that made me excited, and we decided to continue.
You started to touch on something that excites me about the phase 2, aside from providing, further diagnostic performance validation and evaluation. My background comes from the, quantitative MRI world, granted more in brain imaging. But when I was introduced to MagSense, I saw a real potential for introducing some of these more quantitative techniques, because it gives the ability to move beyond just visual interpretation. Now we can actually tell something concrete about the data that we're seeing, and then eventually, lead to the development of, automated or AI diagnostic tools. Can you talk about how the development of those sorts of tools may be helpful in the in nodal staging and in the management of HER2 breast cancer?
HER2 positive breast cancer involve about 10-15% of breast cancer. Is the less common type of breast cancer.
Mm-hmm.
But the problem is that this is the lethal part of the breast cancer. Unfortunately, the cells act very aggressively and can kill the patient. The good news is that we have very effective treatment for this particular type of cells too. Imagine that at some point, we may not limit ourselves to axilla. We may want to evaluate the breast tumor with this one too. If we know that the HER2 positive breast cancer can kill the patient, and if we scan with this is a hypothetical thing. We are thinking about future. This is not the standard of clinic now. But I can see that in the future, probably we'll have contrast agent that we use to avoid even biopsy of the breast itself and know the molecular profile of breast cancer or maybe other cancers with molecular type of contrast agent. Like one of the examples is the one that you are working on. This is a step toward changing the way we interpret MRI from a general contrast agent that goes anywhere that the vessels are leaky, moving away from that non-specific type of contrast into a molecular type of contrast. And the importance of that is that once this works, there are many other diseases, ovarian cancer, I saw PSMA for prostate cancer, and many other liver diseases. There are so many other potential for this type of approach, meaning that instead of having a general contrast agent that does everything, have a specific disease, a specific contrast agent that can show you the molecular profile of that one. What I see is even beyond breast cancer. We are using breast cancer as an example, HER2 positive breast cancer, as an example of the application for this technology, but the future of this technology can affect many type of diseases, even maybe beyond cancer too.
Yeah, and that's something I think is most exciting about MagSense overall, is that it's a real platform technology, and we are working on applications beyond HER2 breast cancer. We have candidates in the pipeline for ovarian cancer and for prostate cancer. And one thing that's so unique about the MagSense platform is that we can pretty much target any type of cancer for which we can find a targeting ligand. So as you're saying, there are applications far beyond the breast. And I think that really has the opportunity to change how we see cancer, how we diagnose cancer, and how we treat it. Many people are familiar with PET, which is another form of molecular imaging. Can you talk about some of the limitations of that technology and how molecular MRI might solve them?
So yes, PET scan is a very useful technology. It's very expensive. Some of the insurance companies now have some limitation in approving them. So sometimes it's not possible for the clinician to use PET just because of the cost of that. The second problem with the PET is the very high dose of radiation to all of the other organs. So if the patient has a breast cancer and you want to evaluate the breast cancer, but you're putting the other organs of that particular patient, including kidneys and bladder, who get a lot of the waste of the material that are still radioactive as a radiation. So you can solve one problem, but you're always limited by how much damage you're causing to the rest of the body of that patient. The second thing is that the regular conventional PET scan, that we call it FDG PET scan, is basically shows the higher metabolic activity. So anything that has metabolic activity will show up. Again, the problem is that it is not specific. You will see additional finding either in bone or other areas of the body that you don't know whether they are related to cancer or they are benign condition. And that leads to additional biopsies, additional tests, additional concern, and sometimes misdiagnosis, because there are lesions in the bone of the patient that are not metastatic, but on the PET they look like metastatic, and the patient may be labeled incorrectly to have metastasis while they don't.
Just before we let you go, it's been a great conversation, and honestly, you've made me more excited about this product and this company, if that was even possible. So it's always great talking with you. But before we go, what would you want cancer patients and the public in general to understand about why this MagSense Phase 2 study is so important?
So I want all of the patients to know that the goal of many investigators around the world is to elongate the life of this cancer patient. But there are certain investigators and companies who also think about the quality of the life during the treatment and after the treatment of breast cancer. So this product is focused on preserving all of the benefits of treatment of the cancer and lowering the harms and post-treatment complication and disabilities for the patient so that they can enjoy their elongated life while the treatment is completed.
Great. Well, Dr. Eghtedari, thank you so much for joining us and spending all this time with us. It's been a real pleasure. And I hope everybody watching has found this informative and exciting. And we look forward to working with you in the Phase 2.
Thank you very much for having me and giving me the opportunity to work with you. And I'm sure that together we can make the life of our cancer patient better. Thank you.